Good evening, everyone. On behalf of the Department of Neurological Surgery, excuse me, Brain Tumor Division, and the Jefferson Multidisciplinary Brain Tumor Center, I'd just like to welcome everyone to the first of four weekly webinars during Brain Tumor Awareness Month. Brain Tumor Awareness Month is intended to recognize the vast number of patients afflicted with brain tumors, their families and friends who support them, and the medical personnel that dedicate their lives to the fight against brain tumors. Tonight's webinar is entitled Ask the Expert. It will be a QA session with a number of previously submitted questions. And our panelists are Dr. Christopher Farrell, Dr. David Andrews, Dr. Michael Lemole, Dr. Hekmat Zarzour, who should be joining us, and myself. There are three other webinars that will follow, weekly sessions on Wednesdays from 6 to 7. Next week will be an introduction to radiation treatment for brain tumors and symptom management. The following week is an update on neuro-oncology clinical trials. And the week after that will be empowering patients and caregivers. It's a resource update from Jefferson and the American Brain Tumor Association. So without further ado, we'll start to entertain some of the questions that were previously submitted. And I think, Sean, if you're going to MC, if you go ahead and start us off. Thank you.
All right. I think I talked to Sean and he and I are going to work together on this. So, again, welcome everybody. We're excited that you're here, and hopefully we're going to have another great Brain Tumor Awareness Month. So we solicited questions from our patients, and we actually got a ton of them. We're not going to be able to get through all of them, but we've sort of looked through and tried to combine some things, and hopefully this will be informative. Dr. Lemole, you want to start us off here? The question is, can brain tumors be hereditary? And what are some of the causes as to why these tumors develop?
And that's a huge topic, and anyone please feel free to chime in, because when you talk about brain tumors, it's a huge category. It's everything from tumors that start elsewhere in the body, say a lung cancer that goes to the brain, a melanoma that goes to the brain, to tumors that actually arise in the substance of the brain, and then tumors that actually arise in the support structures of the brain all around. And each of those can have completely different genetic influences. So no doubt we know that certain genetic inheritance conditions will predispose you to things like acoustic neuromas. Those are generally benign tumors in the nerves that basically support your balance structures at the base of the skull. And they can also have a predilection towards other kinds of tumors in the actual brain itself. We know that there are genetic predispositions towards tumors that metastasize to the brain as well. We know that people who have certain types of meningiomas, generally also a benign tumor that tends to occur sporadically, that people who have clusters of these tumors may have a genetic component as well. Some of them are very clear associations with a single gene or cluster of genes. Other ones, we just noticed the genetic trend, but a very broad topic. I think the most important thing you need to discuss with your surgeon or your neurologist or your oncologist is, what is my tumor? How is that tumor relating to me? And does it relate to my family? Is there anything about my condition that would make this genetic as opposed to a sporadic occurrence? If anyone wants to chime in on any specific examples, that might be illustrative.
Yeah. So Jim, sometimes you don't know for sure if it's genetic, and it might have. Are there ways that we can sort of fully answer that question about the genetics of a patient, and how do we do that?
Well, at times we need to get genetic counseling. If we're suspicious of a condition, I think Mike alluded to neurofibromatosis or some of the conditions that might lead to acoustic neuromas, et cetera, and other tumors in the brain. Sometimes you got to refer for genetic counseling. And that'll be a matter of taking a good history from the patient and family, which is really paramount, examining the patient and then doing blood work, looking for specific markers. We know a few. There's gazillions of genes and mutations and up and down regulation that takes place to make a single tumor grow. But we know a few that are pretty classic and pretty pathognomonic that we can test for with blood tests. It's a common question we get, will my kids get this, or is someone going to inherit this from me? Many of the things we see and treat are not. Even really common tumors that we treat a lot, like pituitary tumors, that we're We manage many patients with them. In very rare cases are they of familial origin or some genetic predisposition. They're usually something more downstream and not typically inherited. They're just super common. So you might find either, a couple in family for some reason, or might find colleagues at work or others that have pituitary tumors just because they're super common, more so than they're being passed on genetically.
One question I'm getting, I get all the time is, do cell phones cause tumors? And a lot of patients are always interested in. And then more recently is, things like the Depo-Provera lawsuit and meningiomas. And some of these things, it just takes so long to figure out. The cell phone question is a tough one. Cell phones don't carry enough electromagnetic energy to mutate the DNA in cells. So we don't really think they cause brain tumors, but it's hard to know, and sometimes it can take decades before you really know. And then this most recent study about Depo-Provera, which is a form of progesterone that's given intramuscularly as a contraceptive. There's one study that showed a very, sort of weak link between meningiomas, and it's got a lot of people nervous. It's a little bit strange where there are so many forms of progesterone and only this one seemed to have an association, but we just don't know yet. Dave, Mike talked a little bit about how there are these range of tumors, benign and cancerous. Can a benign tumor, one question is, can a benign tumor like a meningioma ever become cancerous?
You're asking me?
Yeah, Dr. Andrews, yep.
Yes. No, I don't think so. The vast majority are benign tumors, the so-called grade 1 meningiomas. The atypical meningiomas are more aggressive, and we tend to treat them even when we do gross total resections with radiation. And then a very rare subgroup is the grade 3 tumors, which are really aggressive. I think in my 36 years in practice, I've seen maybe 3 or 4 of those. So you tend to want to be really aggressive there, but there's not a lot we can do. And I don't think there's been a lot in terms of medical treatment after resection that improves the longevity of these patients.
Yeah. So it's, a lot of times we don't have a biopsy. You get an MRI and you see what looks like a acoustic neuroma or a meningioma or a pituitary tumor. And patients ask, how do you know it's benign? What would you say to that?
Well, so I don't think we can really answer that question with radiographic information for meningiomas. I think it's a different story when we get to malignant primary tumors of the brain like gliomas. And even in that case, as much as we want advanced information as quickly as possible and also information about the nature of these tumors, we're getting into radiographic assessments of what artificial intelligence can do to make us as physicians help patients even before they hit the operating room.
Yeah. So sort of, so basically we can look at the MRI scan and generally tell pretty quickly between tend to be more aggressive tumors like the gliomas and the benign tumors just by the way they look. And fortunately for things like meningiomas, more than 99% are benign. And the more aggressive ones tend to have red flags. So Kevin, we're joined by Dr. Judy. When you look at a scan and you think it's a benign tumor, what kinds of things are you looking for that might suggest it's a more aggressive tumor? And then the other question is, how do you know if these tumors are going to grow, and is it okay to just leave some of these things alone?
So I was having some video problems. When we look at the scans on patients with tumors, there are certain red flags you look for. And those are what appears to be invasion of the brain by the tumor so that the edge is not well defined, that it's fuzzy. The edema pattern is the tumor causing any inflammatory reaction within the brain, and swelling. We certainly look for mass effect or pressure on the brain brain compression that is beyond just the size of the tumor. So that if you have a tumor that's 2 centimeters in diameter, but it has 3 centimeters of edema surrounding it, that's 5 centimeters of pressure on the brain. So we're looking for these things as red flags. Also, depending on the appearance of the tumor, some benign tumors like meningiomas enhance or light up with the dye very well. But other tumors, such as gliomas that are intrinsic within the brain tissue itself, lighting up with dye is a bad sign for those. So there are these signals we get from the MRI scan that help us sort out whether the tumor appears to be aggressive or not.
And then I guess, Dr. Evans, to follow up on that, if it doesn't look like it's aggressive and it's a benign tumor, is it okay to leave it alone? And how do you make the decision about whether to treat it or not?
There's a lot of factors, Chris. In addition to the findings that were discussed, I would say also calcification within, just speaking about a meningioma, those that are calcified, not the calcium around them, but those that are highly calcified tend to be slow growing. So the big trouble comes when it's the first finding. It's the first initial discovery of this this tumor. Again, say a meningioma, since we're talking about tumors that we may watch. And that's tricky, right? Patient's kind of shocked. They've got a new diagnosis and trying to come to grips or come to terms with the fact they've got a tumor. And then, how can it affect me? What do we do about it? How do you, all these questions, how do you know it's benign? And then sometimes we'll suggest, based on the fact that it's a first finding, maybe it's incidental, picked up for imaging for some other reason, a bump on the head or a headache or something that may be unassociated. And they're not symptomatic. And at that point, we kind of decide, well, if they're not really having symptoms, we have no evidence of progression on over serial imaging. Maybe we can sit tight. It's okay to keep a watch and start with maybe a shorter interval in the beginning. Gives some peace of mind and help to weed out the rare meningioma that's growing more quickly. And then we sort of start along this pathway of maybe a few months and maybe 6 months, maybe a year, and then you'll see it'll kind of build out. Some patients we've been watching for 10 and 15 years and still haven't needed surgery, but it allows us to keep a close surveillance for growth while we also watch for any new symptoms that may come along. It's a tricky thing, and it's a very individual thing, patient to patient. Some can swallow that and would rather not have surgery if at all possible, and others say, no, that doesn't belong there. I want it out. And probably the reality is somewhere in the middle. And it's having that kind of good discussion and negotiation, have a good understanding where everyone stands and what the goals and expectations are. It helps us to kind of build that, that treatment plan or that observation plan.
And you mentioned the presence of calcium. Someone asked, does the calcium protect my tumor from growing?
So again, I feel like we're stuck on meningiomas, but the heavily calcified meningiomas tend to be the slower growing ones. So we'll find these often, small or heavily calcified, really asymptomatic, probably been there a long time. I don't know that the term protected from growing is necessarily exactly accurate, but there may be some association that they tend to be slower growing. The other thing I would just throw in is we talk about the different grades of meningiomas, and we know that, more recently there's probably more grades than we realize. We talk about sort of grade 1, 2, and 3 as Dr. Andrews outlined. But even within grade 1 tumors, there are those that act much more aggressive and tend to turn around and grow and recur and can be problematic. And, we look at that and think, okay, great, low grade, low, World Health Organization grade, and probably in good shape with a good removal. And next thing you know, tumor can recur or progress. And they can still be problematic. So I think there's more than we think to these grades, but we sort of roughly put them into 3 grades still.
Yeah. I mean, we've been going with this 3-grade system for decades and decades, but meanwhile, we've realized that on a genetic and epigenetic, all sorts of bases, these tumors can be very, very different. And that's probably why some are the size of a pea and some are the size of an orange, and why some grow fast and others. So, we're rapidly figuring those things out. And I think those things are going to make a big difference in the next, they're already making a big difference, but they'll continue to make more and more of a difference, especially as we have more treatments. Dr. Lemole, people talk about the treatment options of surgery, watching it, for almost all these tumors, watching it, surgery, radiation, medical therapy. When is surgery always an option for a patient, and when is it not an option?
As you said earlier, I think it's always, and I think Jim said this as well, it's always got to be a discussion. There are some situations where would say surgery should not be your first go-to. And I always try to break the categories of what a patient can do into at least four buckets. One is to just do what we'd already talked about here, getting serial imaging, watch and see what it does. And if the tumor never grows over your remaining lifespan and we think it's benign based on appearance, then really nothing to do. One is, of course, surgery in all its forms. One is radiation, upfront radiation. Oftentimes we will use radiation in conjunction with surgery before or after, but by itself it is an acceptable treatment. And then that rare case of having a medical treatment for a tumor that is very targeted. So the classic example is a prolactinoma. We have medications which we can give to a patient with a prolactinoma, may literally shrink their tumor away and they can avoid surgery. So that would be a case where I would say if a patient came to me and said, I have a prolactinoma, it's small, it's not eroding their skull base, it's not causing direct compression, say on the eye nerves that needs immediate decompression, I would say surgery is not a good option in that case. And I'm sure you can find other options across the boards, but that's the one that comes to mind where we have a good medical solution.
Um, and then we had a lot of questions about radiation and what's the difference between these things. Dr. Andrews, you sort of brought focused radiation, stereotactic radiation to Philadelphia. What's the difference between, gamma knife, cyber knife, proton beam, linear accelerators? What's the difference, and how do you use them for different things? Are they interchangeable?
They are interchangeable. I think so the gamma knife was the revolution, I think, in the late 80s when it was Lars Leksell in Sweden that came up with this concept of focusing radiation for tumors. And it came to the United States at the University of Pittsburgh with Dave Lunsford. And that was the beginning of a revolution for us as neurosurgeons. That was always based on a single fraction treatment and a very precise way of delivering that treatment. Linear accelerators were behind that, but there was a process going on in Boston at Harvard where they now started to develop linear accelerators, which is another way we're talking about photonic energy, photons of energy. Gamma knife and linear accelerators are delivering photon energy, which is to be distinguished from proton energy, which are these proton units. So what's happened, just to make a long story short, is the LINAC system was much more favorable to the idea of delivering small packets of radiation over time. That was safer for the patient and was much more effective in certain situations, particularly vision for optic nerve sheath meningiomas. So that has actually prevailed. Gamma knives are just because it's a cobalt source and although it was really the game changer in the late 80s, it's actually been replaced, I think, predominantly by actually LINAC-based systems. And they're very effective for a lot of benign tumors and as a boost therapy for malignant tumors.
So all of these different commercial machines have the ability to deliver radiation energy in very precise ways to a tumor and effectively try to kill that tumor. And over these 30 or, really it's almost 45 years that we've had these things in Philadelphia, right? We've kind of figured out how to use them, what the safe doses are around. It doesn't mean that we've completely, it's not a perfect thing, but it's really revolutionized the way we treat a lot of these tumors.
Yeah, I would say it's true, Chris. A lot of the systems have sort of converged now that they're very similar, right? You hear about all the knives, cyber knife and gamma knife and this guy's knife and that guy's knife. They're all very, very similar in a way, and they're going to get you there. You might drive a Chevy to work and I drive a Ford, but they both get us to work. And they'll deliver a very precise energy, and they'll be advertised different ways. And whether proton, the heavy particle radiation is the thing on the corner now being marketed, or whether it's some linear accelerator or whatever it was. Tomotherapy's come and gone, and could name a number of different systems. But you're right, they're all kind of very similar in a way. They've got their subtle nuances with programming and planning, but they deliver the dose in a very accurate way, whether by single dose radiosurgery or, as Dr. Andrews alluded to, fractionation, small doses over time to keep the brain or surrounding structures safe. I think they're probably pretty similar. It's rare that one really shines over another consistently.
That's
And
a
Chris,
it's a good segue into. So Dr. Andrews brought radiation to Philadelphia. Jim, you really brought minimally invasive surgery to Philadelphia. And the question is, what's the difference between minimally invasive surgery and craniotomy?
It's interesting, minimally invasive would imply small incision, small opening. We like to think of it as minimal destruction, if possible. So we use different access points to reach tumors that might be tricky from traditional open craniotomy, making an incision in the scalp and opening the skull and looking in and using cranial-based techniques, which is really to get lower down toward tumors at the base of the skull and getting creative with removing, normal structures to access the tumor safely. The endoscopic, certainly endoscopic endonasal, and there's a number of ways we use the endoscope, but endonasal or transoral, transnasal, transoral were really revolutions to reach tumors that were in the central part of the cranial base. It was tricky to do a craniotomy and cross the brain, or have to elevate the brain, or cross critical structures like the optic nerves or the carotid artery, etc. This allowed us to work in this space between all these structures more directly, with less morbidity. So we tried to manipulate and damage less normal structures that are uninvolved with the tumor, and try to really focus on just accessing the tumor. So minimally invasive has a number of different connotations. That's also a long dissertation, I would say, to discuss. But the idea of smaller incisions, less destruction of normal anatomy, or potentially endoscopic, which would be, minimal or no incision.
Right. Always trying to find the best way to treat the tumor in the most successful way and the least destructive in terms of injuring the brain sort of way. And Dr. Judy, there's a question about, what about awake craniotomy? What is that, and when do you use that?
Well, awake craniotomy is really an anesthesia technique in which there are a couple ways of doing it. The patient can be awake throughout the whole operation. My preference is the patient's heavily sedated, then woken up, and then put back to sleep. And it's really used a lot for language mapping in the operating room. So when we have a tumor or a lesion to operate on that's near one of the major language areas in the brain, there are two. One's right here on the left side, Broca's, and one further back, Wernicke's. We have the patient heavily sedated. We roll them on their side so that you're as if you're lying on your sofa watching a football game. And then we numb you up and put you in this device that holds your head very still. And then because the brain, we're taking advantage of the fact that the brain has no sensation. So we numb things up with Novocaine. We open the skin, we open the skull, and then we wake the person up. And then we have our neurologists in the room, and they speak to the patient, ask them questions. We build a tent, like when you were in third grade on a rainy day. We build a tent around the patient's head so that they can see out. And we ask a series of questions. And while they're asking questions, I have a little probe that I'm stimulating the brain with. And if I can stop you from speaking, that means that's the language area. And then we work around those active language areas to take the tumor out as much as possible, hopefully all of it. Some people use awake craniotomies also for motor mapping. I've not been that successful with that. I like motor mapping with the patient asleep. We've had
By
very
motor
good success with
mapping,
that, and it's a lot
what do you mean by motor
less
mapping?
stressful. I'm sorry?
What do you mean by motor mapping?
That's where we map out the strength areas of the brain. So you have a strip of tissue about 15 millimeters wide that goes from the top of your head down to your ear, and that's what works the opposite side of your body. That's called the motor strip. So the right side of your brain works the left side of your body and vice versa. And frequently tumors are near these motor areas. And so we, again, after you're asleep, we put little needles in your muscles on the opposite side of the body, and we directly stimulate the brain to try to activate the motor fibers. And there's a nice paradigm in which the amount of current needed to activate the motor fibers has an approximate correlation to how far you are from the nerves. So I'm sorry, that's why I was a little bit late here. I just got out of the operating room a little while ago, and we had several cases of motor mapping today.
So you can tell how a patient's, if you're preserving their strength and sensation areas while the patient's asleep as you're operating and sort of interrogate those systems.
Yes, yes. And we also run what are called motor evoked potentials and somatosensory evoked potentials. So their sensory is separate from motor. That is, touch and feel is separate from strength. But we can monitor all of that from the brain through the spinal cord. And we do that real time while we're doing the operation. And then we take time out to do the direct motor stimulation also.
But the speech areas, while we can have some idea of where they are with special scans like functional MRIs, you need that patient feedback to make sure that you're safely operating in those areas, correct?
Absolutely. Yes, we can get changes where a person can still speak, but they're mumbling a little bit, and that tells you you're getting close. And so those are the things we work with the epilepsy neurologists who are very good at identifying any language problems during surgery. And they'll frequently warn us just as we're getting close to something before we get into real trouble and damage language area.
Yeah. So, some really complex surgeries require a lot of expertise and experience. And Dr. Lemole, we got a bunch of questions about sort of how does a brain tumor surgeon train to become a brain tumor surgeon? How would you answer that?
Yeah, that's important for everyone to understand because it's not a show up to a night seminar and you get your certificate. When you think about it, so everyone can sort of relate to the shared experience of going off to high school and many people going off to university, but that's really when the medical journey starts. And you got 4 years of medical school, and then to become a brain surgeon, you've got at least another 7 years of residency. And this is hands-on learning, but still very academic, taking tests, doing certifications. And then even after that, many neurosurgeons will go on and do fellowship, which could be an additional 1 or 2 years. And so it's a long process, and at every step along the way, and as Chris, you and Jim can speak to this as well. The residency body itself, the board, is very regulated, and we have milestones that we have to check the residents off and say that they've shown enough good judgment when it comes to treating patients or when it comes to showing their ability to respond to new situations. And we actually can rate their ability to perform a certain type of case independently. And that's really, really important that the patients understand and have that confidence that when someone says they are a board eligible or board certified neurosurgeon, they actually have gone through this rigorous process. Really, really important.
Like I would add to that many times we're asked by patients, "Oh, you're a teaching hospital. Does that mean I'm going to be turned loose to a bunch of medical students or residents or that sort of thing?" And I think people are not quite at ease with that sometimes. Often, where I reflect on that is that's how we all got here. Everyone you're seeing here was a resident at some point and a fellow, and then went through their various levels of training. And it's important that we have our residents and fellows working with us. If we aren't able to achieve that, that's why this academic center concept is so important. If we can't achieve that, there'll be nobody there tomorrow to do this. And that's
And,
how we
and
all got here in the beginning.
And I like to reassure the patients, though, on top of that, that yes, this is what allows the next generation of doctors to do surgeries down the road. But also on top of that, I'm still the captain of the ship, and I'm only going to delegate to that resident what I know, absolutely know, because I've watched them. It's a hands-on apprentice style residency. I've watched them do it. I will only delegate to them what I know they can do. And that's part of the training process. Just like it's like it really is an apprenticeship. People talk about it a job, or is it how? What does the job actually entail? But it's really like the old apprenticeship. Someone comes and sits next to you. They learn. At first, they're an apprentice, then they're a journeyman, then they become the master.
I think that there's also, a lot of these surgeries require more than just the two hands of a single surgeon.
Absolutely.
I am a better surgeon when I have a good assistant. And at a place like Jefferson, we always have a good assistant, and it's usually somebody that's been doing this for years and years. And then there are cases where, really tough ones where we as partners, I mean, we talk all the time about cases. We show each other films. We say, what would you do? Our tumor boards are constant discussions. And there are definitely cases where we're all in the room together working for some of these very challenging, especially these long ones where your body just starts to break down after a while. So, that's what having a brain tumor team is.
The other thing I would add too, Chris, of the residents and fellows, it's important is that they know the operation. They're also 24/7 in the hospital and
Yeah.
available to take good care of patients. And that's equally important. We're available ourselves all the time, but can only be in one place at a time. And having the addition of the residents and fellows, everyone around is a really great advantage. Rather than going to a local hospital where you may have just the neurosurgeon and he may be your surgeon through and through, but he's the only guy that's around. And when he's home, he's home. And I think this kind of backup and care you can provide at a university center is bar none, I think, better for patients.
I think patients always ask, should I have my surgery on a Friday? There will be no one around on the weekend. I can assure you there is no difference. As much as I would like it, Saturday and Sunday are no different than Monday and Tuesday, where there's always somebody, a whole team ready. Um, you know, Dr. Andrews, when you have a really challenging surgery, how do you mentally prepare for that? How do you plan for that surgery?
Well, so you begin with where is the lesion and does it look benign or malignant? In either case, we break the brain down into areas of eloquent function and non-eloquent function. So Dr. Judy really, I think, framed eloquent regions of the brain, including speech, motor function, vision is another one. Non-eloquent regions of the brain, we have the most latitude in the right frontal lobe because most of us as individuals are right-handed. So our right frontal lobe is the non-dominant. So we can take out hundreds of grams of tissue with no concern about the outcome. Whereas in other areas, the margin for error is much narrower. So I think the preoperative preparation for these patients, first you have to have some idea of what you think you're dealing with, and you discuss this with the patients. What are the risks and benefits? And we always start with risks, and risks could be a consequence of where you are. So it could be a meningioma that's near speech, but it's aggressive. So you're talking about removing this, but you're near speech. So a consequence of doing this operation is you could have a speech disturbance. But based on the velocity of growth of this tumor, the worst scenario is doing nothing because you will lose your speech. So you mitigate, I think, situations with patients talking about risk and benefit. And of course, as surgeons, when we recommend surgery, we obviously say the benefit outweighs the risk.
So we're constantly trying to do that risk benefit equation based on how we think the tumor is going to behave, where it's located and how safely we can access it. If it's in a very tough spot, we may have to come up with creative corridors to get around those eloquent or dangerous spots. But it's amazing how during my residency time training and now the idea of inoperable tumor, it is extremely rare these days that we say a tumor is inoperable. It may be that we have a better treatment than operating, but we can get to areas that many people thought we could never get to.
Yes, I would add, digesting the films, looking at the MRI, the CT, adding additional imaging to really kind of get a good sense as to what the tumor character is, its exact location, how we might access it. And for patient standpoint, that's something we do even after we see you. We may go back and revisit the films. And the other thing is talking to colleagues, as Dr. Farrell alluded to a few minutes ago, not just the crew you see here, but our colleagues in other specialties. It's really a multidisciplinary effort where we have radiation oncology and neuro-oncology and a host of other specialists you may see, ENT, et cetera, ophthalmology, that we'll discuss our patients with, their condition, the imaging, et cetera, and then come up with the best consensus and the best treatment plan.
And I would add in a psychological preparation, and I don't know what you guys feel about this, but I actually, some days before the surgery, I actually start playing the movie reel out in my head. I literally imagine, what does it look like once the bone is off, once I open the lining, once I'm underneath the frontal lobe, what structures will I see first? And and people have talked about visualization as a really important tool that athletes and high performers use. And I think surgeons use it. We don't all talk about it, but I know that I do it because I'm literally the night before going over these reels in my mind. And they're probably reels that are composites of all the other cases I've done that are similar. But I think that's really important because you start to not only imagine your success, but in that process, I'm imagining all the things that could go wrong and what would I do? What would I do to deal with that? And as a result, if that pops up, I've already got a set menu of steps that I'm going to do to deal with a difficult complication.
I mean, I think the reality is looking at this panel, every single one of us basically only treats tumors and has only been treating brain tumors for more than 15 or 20 years. So we have a pretty good idea of what we're going to see when we get down there based on all our experience. There are new tools, things like virtual reality, and Dr. Andrews' son is actually a world leader in this, of trying to help people who've done this, maybe fewer times, play that reel in their head and really anticipate what's going to happen. Dr. Judy, patients they sort of want to know, what should I expect after a brain surgery for a tumor?
Well, it varies greatly. I mean, we just talked about the important parts of the brain, and I tell my patients it's like real estate: location, location, location. So the right frontal lobe, Alaskan tundra, you set off a bomb, you won't hurt anybody. Left frontal lobe, temporal tips, Montana, you might hurt someone. The motor strip that we talked about is Gladwin. The deeper part of the brain is the basal ganglia is Center City, and the brain stem is Manhattan. So it depends on where your tumor is. A right frontal tumor, patients typically, in my experience, surgery takes 3 or 4 hours, go home in 2 or 3 days, and in about 4 to 6 weeks, they're up and moving about. If you come in with some kind of a deficit, an injury, and you're already weak on your left side, it's very common for, even if a perfect operation, you still need to go to inpatient rehab for a while. So in general, it depends on how you come into the operation, what kind of problems you have, because those problems aren't going to be immediately corrected. It's going to take a while for the brain to recover. So that a straightforward operation, a simple operation, you go home in 2 or 3 days. The biggest problem is your stamina, your energy level. You get up in the morning, you're ready to go. By 10:30, you're done for your first nap of the day. And then gradually you get back to being annoyed that the house isn't as clean as you think, and then that's a sign of recovery. Other patients need a couple weeks in inpatient rehab in order to get their strength up. And then the next question is, what kind of tumor do you have? Is it a malignant tumor? Are you going to need radiation or chemotherapy? And radiation, just as you're really hitting your stride, feeling better, that's when radiation comes in and affects your stamina. We're radiating the brain, not the GI tract, so there's no nausea or vomiting involved. But it's recognized that your brain is one of the most important organs that you have, and it already uses 25 to 30% of your total energy level. So when it's injured by one of any of us operating on you, and then you get radiation on top of that, it can take a month or two to recover following the radiation. But you should be able to go home and care for yourself, feed yourself, bathe yourself, dress yourself. Um, Everybody's worried about going home and being a vegetable, and that's not the typical case at all.
I think sometimes people are shocked. Not every surgery goes as smoothly as we like, but um, the majority of surgeries do go very smoothly, and we usually have a pretty good idea of how the patient's going to do going into the surgery and what the risks are going to be.
That's right.
Dr. Evans, there's a question about, you know, surgeon says everything went well, the scan looks good, but patient's still having headaches or other symptoms afterwards. Is that normal? How would you counsel the patient?
Oh, it's wide open as well. It's not uncommon to have headaches after surgery some period of time. Again, it's not as long typically as you might expect or might think. So there's different components to this. One is incisional pain, which can be conceived as a headache, but the incision itself, the muscle, the skin, the parts that hurt, as you said, the brain doesn't have nerve endings in it that you can feel pain, but incisional pain can last for a number of days. Sometimes when we operate, we need to drain spinal fluid or just passively spinal fluid will drain and air will get inside. That can contribute to headaches for a number more days and take some time to absorb, a little variably among patients and maybe a little longer in older patients. And then if there's an ongoing problem with a headache that's just either persistent or maybe got better and gets worse after a period of time, then we start to get maybe a bit concerned. Some weeks out, we might be worried there's some new swelling or maybe even tumor progression if it's a malignancy, maybe concerned about infection or that kind of inflammation or infection. So there can be a number of things once you start to get a few weeks of headaches persist. For the most part, I think that first week or so is probably the worst of it. Maybe into that second week, things should be cooling down.
Yeah.
Does that help, Chris?
I think so. And as you said, it's very common to have some headaches after surgery. Everybody's different. It's, why there are people that have headaches every day and some people who never had a headache in their life. There are factors that predispose people to having them. And I generally know, a younger woman who has terrible migraines, I'm probably going to make that worse for a while. And we factor that in as to whether surgery is the best way to go or not. But fortunately, most of these do get better, and we've got some great partners in neurology that we can turn to and a lot of new medications, but none of, they're definitely not perfect.
Chris, just for our neurosurgery staff, there are chats coming in with questions.
Yep.
So if you're not the one speaking, we can collectively answer these questions.
Yeah, and feel free, we got a series of questions submitted, but feel free to try to submit questions from the audience and we'll do our best to get it. Dave, do you want to, here's a great question that was asked about, does Jefferson have any plans for immunotherapy CAR T therapy for glioblastoma?
We don't, and for a couple of reasons. One, because I've just finished a trial which is different, but an immunotherapy. CAR T cells are obviously it's a way of activating T cells in the body to fight a cancer. And that's turned out to be, and this is Carl June at Penn, had great success with liquid cancers. Solid tumors are much more difficult. And the microenvironment of solid tumors are such that, first of all, getting engineered CAR T cells, which is a way of activating those cells in your body with the tumor to allow not us as neurosurgeons, but actually the immune system to mop up what's left of the disease that you're dealing with. But outside of liquid cancers, that barrier is much more difficult to achieve. And thus CAR T cells have been, first of all, they're extraordinarily expensive. And it takes up to a month to 6 weeks to actually develop CAR T cells for a particular patient. And the results so far for solid tumors, and particularly in the space that we're in with glioblastoma, there's been very little effect.
So there's, this idea of using immunotherapy, the body's own immune system. There are so many different types of strategies to rev that immune system up and make it go after the tumor. CAR T cells is one. Your clinical trial is a different one. There are off the shelf type things that we're using for lung cancer and these things. Which, I mean, I would say we're all very actively looking at this and trying to figure out where they fit for brain tumors. But brain tumors are so challenging right now. And the brain is a challenging space to use them. But I mean, there's exciting things going on, and Dave, your research is at the forefront of that. Um, you know,
And Chris, there was that CAR T cell from Mass General, that CAR T cell study that was done and published in the New England Journal of Medicine. It was very exciting, but the problem was it wasn't sustained. There was a very dramatic result, and then within weeks, it was gone. And that was one of the problems with trying to treat malignant gliomas with CAR T cell.
yeah, and the tumors can change. They're constantly evolving, and we're chasing after them with our therapies and but I mean, it's an exciting world in terms of new things that we're going after. Much different than the traditional chemotherapy ways we did it for forever before. Um, you know, swoop, and I know we're sort of switching around from different tumors, from malignant to benign, and we're just following the questions. Dr. Evans, there's some questions about um, PET scans for meningiomas and Ki-67 index. You want to discuss that a little bit?
Yeah, that's a bit tricky. We still have these three grades we rely on, and we try to add to it with things like Ki-67. We think in terms of the percentage of this is showing us how many cells or percentage of cells that are dividing. So it's showing that there's growth or activity in a tumor. We use about 4% as a cutoff, as a kind of loose rule of thumb. And if we have a grade 1 tumor, for instance, with a low Ki-67, 1%, 2%, maybe less likely to recur. But we said there's always exceptions to that. And we're finding that there are some otherwise seemingly grade 1 tumors with low indices that do recur and do take off and don't seem to follow the rules for recurrence and progression and growth. But it's a rule of thumb we use, and it might help us to determine when we may want to deliver radiation. If a tumor has some residual that we couldn't get out, or looks well removed but has a higher grade or very high Ki-67, we might lean toward radiation or having a low threshold to start if there's any change as we're under surveillance. PET scanning is kind of tricky. SUV often used for cancers, for different types of cancers we see, and in the cranial base, for instance, and the head and neck cancers, sinonasal cancers that go to the brain. It is utilized. Certainly a higher SUV would be a more active tumor. It's not a standard, I would say. We use dotatate PET scanning as a way to determine if a tumor is a meningioma, or to screen for small changes or other meningiomas. About 20% of patients will have more than one. I think PET scan and certainly dotatate can be very helpful in that regard. But I think we're going to find this more, certainly to the molecular classification, specifically of meningiomas as we go forward.
Yeah, these sort of PET MRIs where you can use different markers and look at the activity of the tumor, different signals. I think that's going to help us predict the behavior of these tumors much more accurately in the future. And, we've done a lot of work with artificial intelligence and combining all these things, and we're always trying to do the right surgery for the right patient.
And it's always the curveball, Chris. We've had patients with more than one meningioma. As I mentioned, about 20% can have more than one. And one may be a grade 1, and maybe another may be a grade 2. And so sometimes you can have in a given patient different grades of meningioma, which is not that common, but happens.
Dr. Lemole, I'll give you a tough one here. Patient's been watching a tumor for 3 years. It's in a very high risk area. How do you determine when it's time to do something about the tumor? And, is there some other ways besides surgery to shrink it?
Yeah, so I like to, when I'm following a patient with a tumor, I like to sort of have them imagine a graph. So on the one, there's one plot line that's basically the tumor's growth on the graph. And that growth is growth in size and also growth in maybe the potential to cause symptoms. Things like swelling. I think Dr. Judy had mentioned, a tumor can be small, but it can have a big halo of swelling around it. So you sort of factor all those in. And then on the other end of the graph is sort of the actuarial, what does the curve of their life look like? And that's why for certain benign or intermediate tumors, someone's 85 years old, they may die of natural causes before this tumor even causes an issue. And it would be a completely different discussion if it's a 20-year-old with that exact same tumor, because that 20-year-old needs to get at least 60, maybe 70 years of life out of this situation, whereas the 85-year-old, based on actuarial tables, it might be 7 years, so to speak. So that's sort of the first way I like to look at it. And then you start looking, do we see this tumor is growing? Can we predict that within 5, 10 years, it's going to get to a size where we say it's going to cause a problem, put structure on a critical nerve, put structure on the brainstem, give you seizures? And if we can predict that, then you start making decisions to say, okay, now it's better to do interventions sooner than later. You know what? Tumors are a whole lot easier to take out technically when they're small. They're easier to hit with radiation when they're small. So once we make the decision with the patient that surgery or radiation or some form of intervention is in the best interest, the sooner the better. It's that inflection point about when you make that decision. And I think each tumor is slightly different. Each patient's own bias is slightly different. Some patients will say, this just terrifies me, the thought of having a tumor in my head, even though it looks benign, it hasn't really grown much at all. Other patients will say, you know what? I have no symptoms whatsoever. Let's see how it goes. And you just have to factor in things like age, how sick or how healthy they are. I always tell patients, I can take your tumor out, but if you have a heart attack on the table, I didn't do you any favors. So balancing all that into it's sort of a hard situation, but I think that's when you start to make the decision. Do you predict this is going to cause a problem, make the patient's life worse? Let's act when it's easier.
Often patients will ask us, but what about getting it done now before I get older? And that's true, right? None of us are going to be any younger or healthier than we are today. But it's tricky sometimes to kind of look at that, to draw those lines out and determine if a tumor is going to be uniformly growing in a linear fashion and when will be the point when it's going to come to a head. Sometimes, as Dr. Lemole saying, it won't necessarily, and surveillance is perfectly fine.
Um, Jim, there's a question about the long-term outcomes of surgery for adult patients with craniopharyngiomas. I know we're running close to on time here, but do you want to quickly answer that one?
That's a long one. That's one of the most challenging tumors I would say we treat in the cranial base anyway. And there's a few different camps in that. I'm trying to achieve a gross total or complete removal versus subtotal removal and radiation. They can be very similar in the long-term outcomes. I would say that when we can achieve a complete removal, we try. Endoscopic endonasal surgery has really revolutionized our ability to remove these tumors, to visualize and to see them and access them and remove them. So we still strive for that when we can, but at what consequence? We've heard a lot about eloquent, parts of the brain, and certainly where craniopharyngioma grows is Grand Central Station. Everything's around it. Critical neurovascular structures, vision, and your endocrine system, et cetera. And so there are times when we need to perform a subtotal removal to prevent further injury, and then go on to radiotherapy. Surgery alone for a subtotal removed tumor often leads to recurrence. At some point, it's rare that it'll sit forever. There's a bit of a heterogeneous, I think, population to craniopharyngiomas as well. Some are more aggressive than others, but often if we get a subtotal removal, we'll give radiotherapy. That really remarkably improves the control rates and the long-term outcome. And so as for surgery alone, to answer your question, Chris, it's try to get it all out, or it's going to come back or grow. Even in the best cases, when we operate and radiate, sometimes these tumors will progress and they can be quite challenging.
And maybe as a final question here, there's a question from the audience about what our thoughts are on Richard Scolyer, who is a pathologist who had done research in Australia that used sort of a cocktail of immunotherapy drugs before and after surgery to try to treat glioblastoma and what we think about that. And I guess the question is really, what do we think are the most exciting things that are coming down the line for brain tumor treatment? And are we getting close to a cure for any of these tumors? So I'd open that all up to the group if anyone wants to take it.
I'll start, Chris. So the immune system is really the future, I think, for a lot of cancers. If we jump out of brain tumors and talk about, for instance, pancreatic cancer, that's an example where CAR T cells can't get to the tumor because of there's a rim of cells around them that don't allow the T cells to get in. And the same is true of the brain with CAR T cells. But if you can retrain the immune system or wake the immune system up, tumors are foreign bodies, ultimately. I mean, our immune system is designed to react to foreign bodies. The trouble with tumors is they will often suppress the response to a foreign body. So anytime there are mutations, which is what actually malignant tumors are, both in the brain and outside the brain, these are translated proteins that the immune system should recognize and do, but then they're then suppressed. So it's this battle between what the tumor is doing to subvert a T cell response versus immunotherapy, which will actually overcome that with actually, it's not just one mutation, it's a whole array of mutations that are unique to each patient. And you want to activate the immune system for all of those immune mutations or mutations that activate different T cell subpopulations. So the sustained response, so if we talk about malignant tumors in the brain, surgery is just the beginning. And Chris has mentioned this and the whole team has mentioned this, and certainly Kevin oversees this. It's a multidisciplinary team after surgery. And certainly something like immunotherapy folds into a much broader approach to this disease than just surgery itself.
We often talk about the fourth modality.
There's been,
I was just going to say we surgery, radiation, chemotherapy, those are the traditional third modalities. We're all looking for that fourth modality, that thing that really changes the course of disease. Kevin, what do you think?
I just wanted to mention that, a lot of our efforts are focused on high-grade gliomas, glioblastomas, but there is a new drug, vorasidenib, that's been approved for low-grade gliomas that shows great potential. So we're increasing our armamentarium beyond the standard glioblastoma. Everybody's worried about that, but now we have something for low-grade gliomas. We have this new PET scan for meningiomas, looking at recurrent meningiomas. So there are a lot of exciting things that are spreading beyond our standard interest in the most aggressive, most malignant tumors, glioblastoma, although that is a bad actor. But we can now look at treatments for these other tumors, which makes it so exciting, because it's like, oh, you have low-grade glioma, you're going to do well, goodbye. But they don't do well because the tumors can come back. And now we actually have treatments for these other tumors, which is what's really remarkable.
I think it's, there are so many different types of tumors, and we've put a lot of our energy into the most aggressive, but probably the area we're closest to curing are some of the benign tumors. Jimmy talked about craniopharyngiomas. These are much simpler type tumors than some of the others from a genetic standpoint. And we really may have drugs that can effectively kill about half the tumors and keep them from coming back. There's even potential to do what's called liquid biopsies, where you can just do a blood draw and tell if the patient has a craniopharyngioma and whether that tumor has that mutation. In patients who've had surgery with us, we may have asked you to collect your blood and your tumor samples, and it's to try to investigate these things. So there are cures in the foreseeable future for some of the tumors, and there's major shifts in the way we treat, the ones we can't cure, but try to manage better. Any
That's what
other?
we do in our spare time where patients don't see us. We're doing research and we're running in the lab and collecting samples and things you hear us talk about briefly. That's
Yeah.
the other, that's what we do in our spare time. But I think we're 7:01. Chris, I want to thank you for being a fantastic MC tonight, for fielding the questions and getting everyone on board. I like to thank the panelists. You guys, I love working with you. It's great to interact with you every time we get a chance. I know all of us could talk about this all night long if we had the opportunity. And I'd like to thank everyone for joining us tonight, and those that have posed questions. And I hope we were able to shed light on some of the things you're asking about. And please, we look forward to having you join us in the next webinar next week, where Dr. Wenyan Shi will give us an introduction to radiation treatment for brain tumors and symptom management. Thank you again, everybody.
These were phenomenal questions. I apologize we couldn't get to all of them. We'll try to get them in the next webinars.
Thank you, everyone. Good night.